Classically, we're taught that there are two big groups of patients. The first, obviously, is the patients with a cardiomyopathy that we're trying to assess their functional capacity and try to help improve their function with medications, see if they're close to needing heart transplant. But I think SHAPE has taken us to a point where we can do a lot more. So any patient that is short of breath, any patient that has dyspnea with exertion, and we don't have an etiology, we don't know why, I will perform a SHAPE on. And the other way I look at it, let's take the reverse. I have a certain group of patients, for example, the obese metabolic syndrome patient, the patient with sleep apnea, and the patient with valvular disease are three examples that I like to work with. These patients are, whether they know it or not, are short of breath. Most of the time they've acclimated, they don't do much, they're quite sedentary. So these are three conditions where I can do a SHAPE and get a baseline. And then, for example, with the valvular patient, we're often replacing the valve based on change in symptoms, such as shortness of breath. Well, now I have a way to quantitate that shortness of breath, and I can take these patients, and when they come in with a change or potential change, I can discern whether it is actually a physiologic change from their valve or something else. In addition, the sleep apnea patient's an excellent example where many patients won't have a test for sleep apnea, or they'll get tested and they'll refuse to use the treatment. They won't take their use their CPAP or get a dental device or whatever. So now I have a way to quantitate where they are functionally with a SHAPE study and use this to motivate them to do the appropriate test or treatment.